Okay, so hi everyone. Thank you so much for joining in today. We really appreciate you for taking your time and also getting to join us today. I know that it has been quite a busy day for most of us and quite engaged in multiple activities. But today is really a great day because we get to hear, a topic that is not really addressed uh, in the aspect that we address it today, and that is AMR. Um, Looking at it from the conflict setting, and it's really important that we also get to understand it from this angle because there's really a lot that goes on, and I think I read your paper, Dr. Rupa, and it was quite really informative, and I think it triggered me to, gain insights on mind also to share this with the team. That was the main trigger why I invited you, and I really appreciate you for your willingness to join us in the session. And despite even us not really having interacted so much before. So thanks so much for your kindness, and we really appreciate. So I don't know whether I am audible. Am I audible enough so that I maybe check whether my network might be wavering, but if I'm audible, then that's okay. So I'll start off by introducing our guest speaker for the day, and that is Dr. Rupa Kanapathipillai. I hope I haven't really spelled the other name wrongly. So thanks so much, Dr. Rupa, for joining us today. We still have more who are joining, but I think they'll join us as we continue so that we don't really take so much time. So Dr. Rupa is an infectious disease physician, and she's also an advisor working with Medecins Sans Frontieres. Most of us here know it as Doctors Without Borders. And she completed her infectious disease training in Melbourne, that's in Australia. And she also remains as a senior medical staff at Monash Health Centre, which is in Melbourne, where she returns to practice clinical infectious disease every year. It's quite encouraging, Dr. Rupa. And so she completed a diploma in tropical medicine and hygiene from Liverpool School of Tropical Medicine, a master's in public health and epidemiology from Columbia University, and an editorial fellowship at the New England Journal of Medicine. And in her work with Medecins Sans Frontieres, or Doctors Without Borders, she focuses on antimicrobial stewardship and support, and now oversees antimicrobial stewardship activities in multiple projects ranging from acute trauma and reconstructive surgery in the Middle East to pediatric sepsis in West Africa. And she also works a lot with colleagues on infection prevention and control, microbiology, and pharmacy to ensure that we have a multidisciplinary approach to AMR in this context. And one of the things that we also have gotten to appreciate from this program is that we really have people from diverse professional expertises. So we really do cherish multidisciplinary engagement. And thank you so much once again, Dr. Rupa, for joining us. It's also really great to hear from you because you've been at the front line, and I think you've seen this, so you'll be presenting to us things that you've really witnessed and you really have a lot of experience about. So thank you so much for joining us, and thank you for accepting our invitation. I really appreciate it. Over to you. Thank you. And you can try and share your slides. I think
okay.
Thank you.
Thank you, Daniel. Bear with me in my lack of tech savvy. Share screen. Can you see my screen?
Yeah, it's now visible.
It's okay.
Okay.
Okay, so I'll begin. Thank you again, Daniel, for the very kind invitation to present. I wanted to take the opportunity to do this because I really think that we need to have a long-term strategy to address antimicrobial resistance, and you guys are the future. This is going to be something that will impact you and affect you, and I think for you to be engaged and involved as soon as possible is essential. And so for me, it was really important to participate in this. So I will begin. So Most of you are probably familiar with this, but for those of you that aren't, I thought I would quickly summarize a little bit the problem with regards to antimicrobial resistance. For several years now, at least since 2014, antimicrobial resistance has been recognized as a global issue. And in 2014, the O'Neill report started to be compiled and eventually published in 2016. And that demonstrated that without a coordinated effort to address antimicrobial resistance, it would really result in quite high mortality, and that the deaths attributable to antimicrobial resistance by 2050 would be extremely large. Around the same time, the WHO, the World Health Organization, set up their first ever mechanism or system to monitor antimicrobial resistance at a global level. So this is surveillance to try to monitor, to document and surveil the types of bacteria and rates of resistance at a global scale. And this slide is data from 2021. And you can see that the dark purple, there's a lot of engagement in this activity, but there are still significant gaps. If you look particularly at sub-Saharan Africa and parts of Asia, there's still enormous gaps. And this is part of one of the major challenges that we face in Doctors Without Borders when we try to address antimicrobial resistance, is this lack of data. And more recently, there was a large systematic analysis published in The Lancet in 2020 that demonstrated that, in fact, mortality attributable to antimicrobial resistance was one of the major causes of death, higher, in fact, than HIV/AIDS, breast cancer, and malaria. And while I think people suspected this, this publication was important in that it really highlighted that this attributable mortality was really disproportionately impacting low and middle income countries. Which begs the question, is there a strategy to address antimicrobial resistance? What are we doing about this globally? So I think the short answer is there is a strategy. And with all good ideas, with all best intentions, the implementation of strategies is often more challenging than the idea or the writing of said strategy. So in 2015, the World Health Assembly, they created a global action plan for antimicrobial resistance. And there were some key objectives. That was to improve awareness and understanding about antimicrobial resistance, to strengthen knowledge and the evidence base through surveillance and research, to reduce the incidence of infection through effective sanitation, infection prevention and control, and to optimize the use of antimicrobial medication in human and animal health, and to develop an economic case for sustainable investment. Great in principle, I think really fantastic objectives. The reality is that there have been some significant challenges with regards to how to do this. So each of the member states in the World Health Assembly agreed to create a national action plan to address antimicrobial resistance. And while it is heartening that 86% have developed action plans, in fact, only 7 of those are in low and middle income countries. So really where the brunt of the problem is, and where the brunt of the problem is going to be, there is very little in terms of action plan development and implementation. And there are some key factors that contribute to this. There is a lack of political commitment and governance. There is challenges with access to early diagnosis in a quality assured laboratory network. There's ongoing challenges with access to appropriate treatment. There is enormous challenges with regards to prevention of infection, likewise enormous challenges with regards to interrupted supply chains. And we come back to this issue of surveillance and evidence generation, which is very limited from low and middle income countries. So let's just step back for a second to ask the question about what is MSF, Medecins Sans Frontieres, or Doctors Without Borders, as some of you may know, doing to address antimicrobial resistance. So because I work for the organization, I'm obliged to tell you all a little bit about it in case you aren't familiar. So Medecins Sans Frontieres, or Doctors Without Borders, is an international, independent medical humanitarian organization that was founded in 1971 by a group of doctors and journalists. And MSF has a charter, it has principles that we adhere to, and that is to provide assistance to populations in distress, irrespective of race, religion, creed, or political convictions, and we observe neutrality and impartiality. And we maintain complete independence from all political, economic, and religious powers. In 2021, we had medical activities in over 70 countries, highlighted in red. And you can see that Doctors Without Borders does a range of different activities, everything from outpatient consults to treating malaria, to vaccinations, to inpatient care for over 1 million patients, care for people who have experienced sexual violence, antiretroviral care, hepatitis C, assistance to migrants and refugees. So a little bit about what gives us the legitimacy to talk about this issue, about antimicrobial resistance in conflict settings. So a lot of the work that MSF does, in fact, the majority of the work that MSF does, is in contexts that are either currently undergoing armed conflict, that's 34% of the places that we work, are currently experiencing internal instability, or are post-conflict. The majority of the work that we do, in fact, is in unstable context. So let's come back to the question at hand, which is drivers of antimicrobial resistance. So if we look at this, so when people started talking about this around 2014, 2015, there was a lot of discussion about the impact of antibiotics on bacteria, and I think this is part of the problem. So those of you who may or may not be aware, because I think we have quite a broad audience in the room or online, in any group of bacteria, and there's bacteria all over us, all over our skin, humans are colonized with bacteria. In all of those bacterial populations, there will be, most of those bacteria are susceptible to antibiotics in most people. There will be a few of those bacterial colonies that are resistant. And when you expose bacteria to antibiotics because someone has an infection, they kill off the susceptible bacteria, but this allows the resistant bacteria to grow because they are not affected by the effect of that antibiotic. And this is so-called natural selection. We realize, though, as more people have thought about this and worked on this issue of drivers of antimicrobial resistance, that it's not that simple. If you look at any individual patient or family depicted here, you could see that, in fact, there are multiple factors which directly and indirectly impact that patient's risk or likelihood of being colonized with more resistant bacteria. So whether they have been hospitalized and have been exposed to so-called hospital-acquired or nosocomial infections or pathogens, the role of waste and wastewater, the role of vectors like birds and flies and bats, the role of antibiotics in farming, the consumption of that produce that has been heavily exposed to antibiotics, waste management, including management of sewerage into the environment. And the picture becomes even more complex when we zoom out even more and think about population level factors. So impacts such as travel, trade, and relevant to this context, to this talk, is really the issue of conflict and displacement, and how does that impact the risk or likelihood of acquiring a multi-drug resistant infection. This was an interesting publication that was published in The Lancet in 2016, and this tried to address the issue, the question of all of these factors, what different mechanisms, what different drivers matter? What matters more than others in terms of driving antimicrobial resistance? So they think that, in fact, the authors postulate that based on their literature review, that human antimicrobial misuse, in fact, was a high driver of antimicrobial resistance. And similarly, animal antimicrobial misuse or overuse, with more limited contribution from environmental contamination, healthcare transmission, vaccination, and so forth, mass drug administration, less so. One of the major limitations about this paper is that their literature review was really studies that mostly came out of high-income contexts. So the authors postulate, and this is probably correct, that the effect is similar but probably greater in low and middle-income countries, but there is a clear knowledge gap there. So this is a publication that MSF did. So this was a piece of research that MSF did, looking at 10 years of caring for patients in one of our surgical reconstructive hospitals. So this is a hospital in Jordan, in Amman, and it does reconstructive surgery on patients from the neighboring countries. So that's Iraq, Syria, Yemen, Palestine. And this study looked at 10 years of treating patients. And there's a few takeaway messages from this table. So one is that it didn't really seem to matter whether patients came from Iraq, Syria, or Yemen. Their rates of resistance for some key pathogens, so this is Enterobacteriaceae, so gram-negatives that are resistant to ceftriaxone, which is commonly used first-line antibiotic in many parts of the world, was similar, whether you came from Iraq, Syria, or Yemen, and it was extremely high. So this is looking at bone and tissue samples in patients who had had injuries to their limbs in the context of being in one of these conflict-affected countries. It was similar for MRSAs, this is methicillin-resistant Staph aureus, in patients from Iraq, Syria, Yemen, and again, very high. So rates of 66%, 52%, 54%. And similar for Pseudomonas aeruginosa resistant to ceftazidime, but these numbers are starting to get a little bit lower and so a little bit harder to generalize. And for Acinetobacter, resistant to carbapenem, I think we can't really generalize a lot from these numbers because they're very, very small. But it's a concerning signal. This is the same study and found that these gram-negatives, so Enterobacteriaceae, in fact, demonstrated high rates of resistance to piperacillin and tazobactam, which is what we would normally consider a second-line antibiotic, and cefepime, high rates of resistance here. And concerningly, starting to see the emergence of resistance to carbapenems, which we would consider more of a third line or towards last line antibiotic in most parts of the world. This was another study that MSF did looking at war injuries in Iraqi civilians. And what we found, in fact, that one of the contributing factors seemed to be in these patients that had high rates of resistance, they had quite delayed presentation. So an average of 19 months from their original injury to seeking care at an MSF facility. That's a long time, that's over a year. And what we also saw was patients that had multiple surgeries prior to being seen in a Doctors Without Borders facility and receiving definitive surgical care. And with all of these interventions, they are exposed to multiple risks, including poor infection prevention and control, the risk of nosocomial infections, the risk of antibiotics which may or may not be appropriate for them because of the lack of diagnostics, because of the lack of familiarity with treating some of these more complex resistant pathogens. And looking overall at some of the so these are some of the publications that MSF has done looking at antimicrobial resistance in conflict zones. We think that some of the drivers, in fact, are the complexity of some of these wounds. They are bone and soft tissue, often chronic infections, usually often with some degree of exposure, so open wounds that become chronic, a delay in accessing optimal treatment, aforementioned multiple surgical interventions, and unregulated use of antimicrobials. So certainly anecdotally, in many of the contexts that I've described, particularly in the Middle East, but also parts of sub-Saharan Africa, the unregulated use of antimicrobials and the over-the-counter availability of often last-line antibiotics, such as meropenem, is really problematic. Of course, it's a challenge when at what point do you intervene? Do you intervene and say, we would like to restrict, we think that policymakers should restrict access to over-the-counter antibiotics? I'm not sure that that's the most appropriate response, given the fact that more people die from lack of access to antibiotics than overuse. But I think that is a very, very nuanced point that needs to be addressed case by case. Poor infection prevent, but we can talk about that in question time if you like. Poor infection prevention and control. Sorry, I'll move this. MDRO colonization, limited microbiology capacity, a lack of AMR surveillance, and a lack of updated empiric treatment regimens. This is another study that was published by, not by MSF, sorry, I don't have to get rid of this, not by MSF, but by another group, which looked at antimicrobial resistance in the context of Syria and tried to identify drivers that were, I don't know how to get rid of this, I'm sorry, it's cutting off the top of my slide, but drivers before and after the onset of conflict and some of their key recommendations. So they similarly thought that availability of antibiotics without prescription was a problem that was present pre-conflict and that contributed as a driver: excessive antimicrobial prescribing, lack of antimicrobial stewardship, poor infection prevention control, non-existent surveillance for nosocomial infections, a lack of microbiologists and infectious diseases specialists, and then due to the conflict, destroyed health infrastructure, fragmentation of health system, an exodus or death of healthcare workers, lack of training for remaining healthcare workers, overcrowding and displacement, lack of availability of antibiotics, overuse of available antibiotics, war trauma, especially by heavy weapons and explosive devices causing contaminated and deeply penetrating injuries, increased use of prosthetic materials, insufficient resources across the board, including lab, including measures for or resources for adequate infection prevention and control. And the consequences of this is the inability to perform bacterial surveillance, unknown prevalence of resistant organisms, very few microbiology laboratories outside of government-controlled areas, a lack of quality control. And what we are seeing in multiple large-scale publications now is the increased morbidity and mortality and potential for nosocomial transmission. They propose different solutions to try to address this. So everything from surveillance to improving quality control, to training and development of key staff, to learning, to making resource available for microbiology and research into surveillance and antimicrobial stewardship. And what you can see is that to do all of this, in fact, takes an enormous amount of resources and coordination, and I don't think it is able to be done by governments alone, particularly in low and middle income countries. And so this publication really calls to international actors, including organizations such as Doctors Without Borders, to address some of these key issues. But I think this gives you some visibility and understanding as to why national action plans are in fact extremely hard to implement. So back to the patient in front of us. So this is a photo from Gaza in 2018. So when you see this in the hospital, it really begs the question, how do I even begin to address this? Where do I start? And so MSF started with a fairly straightforward pyramid of activity. And the foundation of that is really infection prevention and control, and then antimicrobial stewardship, and then access to reliable microbiology. And we broke this up into two different types of packages. One is a so-called full package with all three elements addressed, and one is the minimum package with just infection prevention control and antimicrobial stewardship. And we tried to implement this in priority projects. So projects where we did reconstructive surgery, where there was intensive care, where we had neonates in HIV programs, and in countries with a high risk of MDRO infections. And we now have multiple sites, you can see, across sub-Saharan Africa and the Middle East and parts of Asia that have this full package being implemented. And we have a strategy to try to implement this across time. So to do it in a staged, planned way rather than an ad hoc way. So to try to recruit IPC, so infection prevention control staff, to try to recruit antimicrobial stewardship staff prior to the implementation of microbiology lab, and to ensure that there are parallel lines of training and support for all of these pillars. If we speak to, and I will speak to antimicrobial stewardship because this is what I focus on for Doctors Without Borders. In our experience, because of many people have discussed the lack of expert healthcare workers to work in this domain in many of these contexts. So our stewardship programs are led by non-specialized doctors who are trained by a combination of an e-learning program and infectious diseases physicians who visit the project and also support remotely. And we've developed tools to help standardize implementation. So this is context-adapted guidelines given the heterogeneity, so the variability in antibiotic resistance in different sites, and to help support surveillance systems to facilitate local cumulative antibiograms. So for those of you that don't know, a cumulative antibiogram is at a hospital level. It's looking at the results, the microbiological results of the patients that come into that hospital, so particularly at blood cultures in the first instance, to say in patients that present with sepsis or develop sepsis as an inpatient, what is the most appropriate antibiotic to treat them with based on the types of bacteria and rates of resistance that are present in this hospital. And we think that based on our experience, that the minimum implementation time for this for stewardship is 6 months. So that's a combination of the e-learning and on-field coaching by an ID physician. We've developed tools within MSF So we can broadly break them down into knowledge and capacity building tools and then monitoring and evaluation tools. So for knowledge and capacity building, it's indication for blood cultures, indication for bone and tissue sampling. We developed a competency framework for learning and development. We developed our own pathogen-specific treatment guide that is evidence-based and peer-reviewed. Similarly, a surgical prophylaxis guide. We also developed a toolkit for antimicrobial stewardship implementation. And excitingly, we developed a 6-month diploma course for our antimicrobial stewards with the British Society of Antimicrobial Chemotherapy. And that is our 6-month e-learning course. And we have an equivalent for infection prevention control focal point. For monitoring and evaluation, we have quantitative tools to measure antimicrobial consumption and qualitative, so to assess the quality of antimicrobial prescribing. And we do this using a point prevalent survey, which is basically a survey done every 6 months to a year in the hospital, looking at all patients on antibiotics, and we review those charts and look at, for those patients on antibiotics, is their antimicrobial prescription appropriate? So for the diagnosis that the patient has, is the dose appropriate? Is the duration appropriate? Is the choice of molecules appropriate, etc.? And from that, we can develop an action plan. We developed a chart review template for a more detailed investigation of a chart from a stewardship perspective, and developed a template for monthly reporting. We realized that in terms of learning and development, that there really needs to be a 10-20-70 approach to this, meaning while the e-learning is fantastic and forms a basis, there needs to be ongoing mentoring, coaching, support from experience and technical experts, subject matter experts, to provide ongoing support. It's not a one and done solution. Switching now to one of the innovations that we have in microbiology. This is just a short video talking about a new tool that MSF developed called AntibioGo. So I'll play this. It only goes for a few minutes, but it's an exciting development in the field of microbiology.
Hello, Dr. Rupa. Maybe you can check it, son.
Can you see this? I don't think there's sound. I think it's just
Okay.
visual. Is that okay?
Yes, it's okay.
So this is basically in contexts where you have limited support for microbiology. This is a mobile phone app that will help you to the lab tech to read the antibiogram discs and be able to determine susceptibility or resistance using an algorithm and artificial intelligence based on so-called expert rules for microbiology. So that is Antibio Go. And we also have the mini lab, which is basically like a lab in a large box. So it's a quality assured, cost efficient, all-in-one transportable clinical bacteriology laboratory that has simplified methods to try to make the process of microbiology diagnostics in low and middle income countries more straightforward. We also have some interesting innovations in infection prevention and control. One of those is the SIPCA, which is a stepwise infection prevention control assessment and improvement approach. So it breaks down some key elements to be addressed in infection prevention control and allows the hospital team to grade themselves. And from that, they can develop, again, an action plan. So it's presented in this lovely dashboard. It demonstrates what areas need to be worked on. And the idea is that the improvement in each of these respective areas contributes to an overall improved score for that hospital. So it's, for a local context, it's annual assessment to be done by the project for the project. We've learned over time that having these vertical pillars needs to be complemented by more transversal innovations or approaches, including learning and development, analysis and advocacy, operational research. And we are seeing, I'm happy to announce that we are seeing a lot more operational research that will be published in the next year or two, coming from our project-based staff who have done some extra training with regards to operational research. So it's wonderful to see them take ownership of this activity, because this is the work that they do, and to see them reflect the work that they do and analyze it and write about it is fantastic. And it's exactly what we need in terms of advocacy and scientific literature. And this is internal, external communication and awareness. So just an overall snapshot of AMR activities in Doctors Without Borders. So 53% of hospitals across all of MSF have an IPC program in place in 2021. 53% of the hospitals that have a surgical program are reporting surgical site infections. There's an average of 74% hand hygiene compliance across MSF. We have 37 projects with antimicrobial stewardship focal points. 41 of those focal points were trained with this MSF Academy e-learning. 26 projects have been using the point prevalence survey or defined daily dose tool in the last 12 months. We have 20 microbiology labs that are currently supporting 24 ABR projects, or this is 24 projects that have this antimicrobial resistance multidisciplinary intervention in place. 7 labs are being used by more than one section in MSF, and we have at least 100 laboratory staff in MSF projects. That's it. So any questions? I can stop sharing my screen. No.
Thank you. Thanks so much, Dr. Rupa, for that really informative presentation. I really appreciate it. I think that's been an eye-opener on the key issues that we face, especially in the conflict settings. Guys, in case you have a question, as you usually do, you can just raise your hand and ask the question, and also you can also type in the chat box. As we start off, I just have one question, Dr. Rupa, that I'd like to ask. And we've talked a bit about antimicrobial stewardship, and I must thank you and your team for the great work that you're doing at MSF. And I think it's really a good step forward. And I think there's a lot of benchmarking that can be done from the work that you've already done, especially in terms of trying to also bring. I don't have experience in this, but trying to trickle down this to even government facilities in these areas. I think it can also help a lot, benchmarking with them and also getting to train them. But let's just to ask about the issue of transition, because you find that sometimes, especially in conflict areas, you might train maybe a health professional cadre, but then maybe conflict arises and you have that many of them then move on, or maybe an MSF had prioritized this area, but then you get another area that really requires your services. So how do you deal with the issue of transition, especially for healthcare workers and healthcare services, to just ensure that you have that sustainable antimicrobial stewardship activities? Thank you.
Yeah, it's an excellent question, and it's one that MSF grapples with a lot. And I think for stewardship, the approach that I am trying to advocate for, and I think we have good demonstration of this, particularly in contexts like Yemen, is to really capacity build the healthcare workers. So we started with one focal point. So we have a trauma hospital in Aden in Yemen, and the focal point there is superb. I mean, he's really outstanding for stewardship, and he has now trained several other focal points in different parts of Yemen. For me, I think there's two things. One is to really be able to support in a meaningful way that is meaningful both within MSF and outside of MSF, the elevation of people like our Dr. Nagwan into positions of authority based on their clinical and lived experience at a national and international level. Because these are the people that are doing the work. And I think some ways that we have tried to do that is to support by supporting further education, so doing a master's in infectious diseases, for example, that helps with some of those questions with regards to legitimacy when you're sitting at a very high level meeting. But so that's one part of it. The other part of it for me is to have this be less centralized, so to have more and more people trained. And I think, so I was just at a meeting a few weeks ago, in fact, to try to create a strategy around this, because ministries of health are asking MSF for training with regards to antimicrobial stewardship, because this is acknowledged in different parts of the world, so in Iraq, in Palestine, that this is something that MSF is doing and can actually support with. And so I think to have this capacity building, and not everyone needs to be trained to the level of an antimicrobial steward. I think but to have some capacity building for other clinicians so that we're a bit more responsible about the use of antimicrobials, to have some capacity building for managers that help support these programs, because they can't exist as a silo. So I think what I'm trying to advocate for is and I think we will have it, is to have training tools for those different audiences. but then how they are shared with ministries of health, then this comes back to the issue of governance and ownership. Ministries of health have to ask for this. We can't impose it, and we would never impose it on an external entity. But if it's something that ministries of health have an appetite for, then I think we're in a position to be able to provide it. But for me, that is the way forward, is to create standardized, evidence-based, robust training tools for different healthcare worker populations.
Thanks so much, Dr. Rupa, for sharing that. It was quite an interesting session for me. So maybe as I wait for the others, maybe it was a question. I also noted something. You talked a bit about the mini lab, and I think I saw the mini lab. I think it was just a newspaper article or something. And I think it's quite an innovative approach, given that you're able to have, your small microbiology setting in one place. And we know that one of the things that really hinders microbiology infrastructure, especially in low and middle income settings, is, the infrastructure, the cost of coming up with infrastructure, the expensive machines and everything. That's why you find even sometimes you have labor, but there's nowhere where you can do the cultures and everything. So maybe how is it in terms of maybe are there conversations or anything that is going on to maybe in partnership or collaboration with other key stakeholders to try and improve the access of these mini labs?
Sure. So it's not just, so mini lab is one, so I should just step back and say, when we talk about access to microbiology in Doctors Without Borders, our approach is this: to go in to do an assessment of what is available in country. So is there a private lab or a Ministry of Health lab that meets quality control standards, that meets international standards for microbiology? And if not, then is there a lab in country that we can support to meet those standards? That's the first question that absolutely needs to be asked. The second question is, well, if that's not an option, then what is the most appropriate for access to microbiology? Is it for MSF to build a conventional microbiology lab? And we've done this in many places, including in Mali, in Central African Republic. So, in different places, MSF has built a purpose-built conventional microbiology lab. And then there is the mini lab, which is a newer innovation, which is like, I think it oversells it a little bit to call it a lab in a box. In truth, it is a lab in a shed. It is, some of the procedures are simplified. The costs are comparable to a conventional lab. And there are some limits and the training time is comparable to a conventional lab. There are some limits in terms of what it can and cannot do. So at the moment, it can only do blood cultures. And that's fine depending on the type of project. So if it's a pediatric project, for example, lots of sepsis, very reasonable to just have access to blood cultures, and we will increase capacity to look at CSF, so cerebrospinal fluid, and urine also. There is also so one of the major limitations, particularly in conflict settings, is the needs for bone and tissue samples. So the mini lab cannot do bone and tissue samples. And for those contexts, we need an MSF-built lab. So we did this in Yemen for Aden Trauma Hospital there. So there's, it has to be weighed up. At the moment, there is a plan to try to externalize the mini lab. So at the moment, it is just in MSF projects, but in the coming 6 months to a year, there is a strategy being developed about how to partner with external actors in other low and middle income countries to externalize the mini lab as a tool.
Yeah, thanks so much. I'm happy to hear about that. Yeah, because it was quite a novel approach, and I think quite a great undertaking. Even if maybe it's limited in terms of its capacity, I think it really helps a lot, especially in areas because sometimes constructing a whole lab, you may not have the time to do all this, and maybe resources to purchase all this for different sessions. Yeah. So I don't see any other question. I think people are still processing. So I think what we can do is that maybe if any other question comes out of the session, I think it's quite a new area. I must appreciate. I think we don't really get to talk so much about this in even most of the sessions. But I think it's an area that people need to address because these are things that happen, and I think also governments need to appreciate. And even in African countries where not just in conflict settings, but even in areas with maybe little resources, arid or semi-arid areas that are facing drought, which has been right now in Nairobi and Kenya, and the Horn of Africa has really been under their situation because of the hunger crisis that was going on. And, these are discussions that we need to have because it doesn't, because the more hungry you are, I think the more susceptible you are to infections and the rest. So I think these are discussions we need to have. So thanks so much, Dr. Rupa. I really do appreciate your kindness. And I think now that we touch base, I think we'll be in more conversations and we'll get to engage more. So thanks so much.
You're so welcome. Thank you so much for the opportunity.
Okay, thank you. Thank you everyone for joining on today. And I wish us a wonderful evening. Most people are in Africa, so I think it's quite kind of evening, and have a wonderful afternoon.
Thank you.
Okay.
Thank
Thanks
you.
so much. Bye bye.
Welcome. Bye all.